Hey, BC here. Welcome to BC Nephro. Thanks for watching. Today I'm going to talk about diabetic nephropathy, diabetic kidney disease. Next in our glomerular proteinuria series. To learn more about the proteinuria series, check out the playlist on this YouTube channel, link in the description below. Also check out the articles at bcnephro.com. Link also will be in the description below. So, diabetic nephropathy, also diabetic kidney disease. What we're going to talk about today is first the natural history of it. Then we're going to talk about clinical variations in real life that deviate from this natural progression. We're going to talk about when you should be thinking about something else and maybe pursuing a kidney biopsy. And then we'll get a little bit into the treatment of diabetic kidney disease. So first, the natural history, natural progression. The natural history, natural progression was initially described for patients with type 1 diabetes. So the first thing is referred to as the hyperfiltration stage. So actually the glomerular filtration rate goes above normal, hyperfiltration because of the diabetic milieu, and this increases glomerular pressure, which turns out not to be good for the kidney. The second thing is what's referred to as the silent stage. That's where there's morphologic changes that can be seen on kidney biopsy, but there is no clinical manifestation. So specifically the kidney function, the GFR is still normal, and there is no albuminuria or microalbuminuria. The third stage is the incipient nephropathy stage. This is when you can detect microalbuminuria, albumin-creatinine ratio of greater than 30. And traditionally in this, the GFR is, the kidney function is still normal, the GFR is still normal. Now this is said to require 5 years of diabetes before this stage occurs. Now the fourth stage is when you progress to overt proteinuria, overt albuminuria, so that's an albumin-to-creatinine ratio of greater than 300. And this is said to require 10 years of diabetes before this occurs. And then the fifth stage is when you start developing a decrease in kidney function, decrease in GFR, kidney failure that often progresses to end-stage kidney disease, uremia requiring dialysis. And this occurs, as I said, in 20 to 40% of patients with diabetes. Now this natural history actually in real life doesn't always work this way. So let me tell you what happens in real life. First of all, in real life we're seeing a lot of patients with type 2 diabetes. With type 1 diabetes, you know when it was the onset is because they got ketoacidosis. Type 2, you don't really know the onset, and there's been a progression likely from impaired fasting glucose to overt diabetes, and there's a lag between that occurring and the diagnosis. So this 5-year deal doesn't really pan out. Second, in real life, it is not always a natural progression. There may be a regression, there may be microalbuminuria that can regress to a normal albuminuria. There may be overt proteinuria, which may regress to microalbuminuria with diabetic control, with blood pressure control, with medications. The third thing is often we will see a decrease in GFR before the development of microalbuminuria or overt albuminuria or without this. So those are some of the things that we see in real life. The next thing we're going to talk about is when chalk up the kidney disease to diabetes and when to think about maybe something else is going on. One situation is that there's a decrease in GFR without significant proteinuria. The second situation is that there is overt proteinuria. Make sure it's not related to diabetes. So what typically happens is a patient presents with proteinuria, it's diabetic. Should I chalk it up to diabetes, or do I need to think about something else? Often in these patients, as an initial screen, if there is significant proteinuria, maybe greater than 1 gram a day, we do a serologic evaluation, which will be linked to in the evaluation of proteinuria article if you want to check that out. The next thing, look for things that are not characteristic or not characteristic with diabetic kidney disease. So first of all, diabetic kidney disease is a microvascular complication. So there typically is other microvascular complications, specifically retinopathy. So if a patient has diabetic retinopathy, that fits with diabetic kidney disease. If not, you may need to think about something else. The other thing is if there's an active sediment. So it does turn out that a lot of patients with diabetic kidney disease do actually have microscopic hematuria, maybe up to 50% of the patients. But they shouldn't have glomerular hematuria, dysmorphic hematuria, CAS, things like that. If something like that's going on, you need to think about another kidney disease. The third thing is the natural history. So did the proteinuria predate diabetes? Or in type 1, did it start happening within the first 5 years, before the first 5 years? And then the rate of progression. So typically, if the amount of proteinuria increases by tenfold quickly, this will raise flags for something else. If the GFR starts decreasing quickly, which is more than 5 milliliters per minute a year, this makes you think about something else. So if any of these situations are going on, you need to think about something else and consider a kidney biopsy. It does turn out that a lot of these cases where we think about something else and we do a kidney biopsy, so patients with a decreased GFR without significant proteinuria, patients who have microscopic hematuria that's not dysmorphic, or patients that have a high level of proteinuria, a lot of them end up having diabetic nephropathy on kidney biopsy. The kidney biopsy for diabetic nephropathy is something called nodular glomerulosclerosis, which is the Kimmel-Wilson lesion, and so this is pathognomonic for diabetic nephropathy, and will occur, as I said, in patients that don't have the classic manifestation more often than not. The other thing is to realize is that this appearance of this nodular glomerulosclerosis can also be seen in something called light chain deposition disease, which happens in paraproteins, myeloma. Should remember is that patients may have background diabetic changes and a second disease on top of it. So the clinical history and nephropathology works together. So getting into the treatment, what we talked about is hyperfiltration. This increased glomerular pressure turns out not to be good for the kidney. So things that decrease hyperfiltration are going to be protective. Glycemic control is going to prevent that hyperfiltration. Blood pressure control to a target of less than 130/80 is going to decrease the glomerular pressure. And then other agents that specifically decrease the glomerular pressure in addition to blood pressure control, so renin-angiotensin system blockers, ACE inhibitors, or angiotensin receptor blockers, they prevent constriction of the efferent arteriole leaving the glomerulus, so will lead to improvement in glomerular pressure. And also SGLT2 inhibitors, which are increasingly being used for both diabetic and non-diabetic kidney disease. They prevent dilatation of the afferent arteriole, limiting the forward pressure coming into the glomerulus. So that's it, diabetic kidney disease. If you have questions, comments, email me at brian@bcnephro.com or leave a comment below. If you made it to the end of the video, subscribe, like this, share it with your friends, and until next time, thanks for watching.